the ISHLT Society has decided we want to capture some of the history of heart and lung transplantation and mechanical circulatory assist devices as the history is developing. And as part of that, we wanted to interview leaders such as yourself in the field of heart and lung transplantation. So I'd like to begin this interview with Dr. Menkis by asking you a few questions. You were born and raised in Canada, and at what point in your life did you decide you wanted to become a physician, and what led you to that decision?
Pleasure to be here, Linda. I guess like most people, I started thinking about what I wanted to do in high school. Before that, I had the usual childhood fantasies of, fire chief or anything like that. But, I thought about being a doctor and thought about being a surgeon at that point in high school, because you have to make your decisions with respect to university. And I didn't think I had the maturity to undertake a decision that might lead me to life and death decisions. So I went into another area of biology, and I went into dentistry.
So had you actually completed dental school?
I did.
You
I finished that. Yeah, I did. I finished. I practiced. I worked for the Canadian government in the Arctic for 2 years, and wonderful 2 years they were. And then after that, I went to med school.
What made you decide to go to med school then at that point?
In an environment like that, there's very little backup in the Arctic. There's very little backup. So you become mature very quickly from a clinical perspective. So I was, just 23 when I graduated, turned 24 quickly thereafter. And in those 2 years, I did an awful lot. It was a very tight community, worked in a small hospital with a surgeon and GP surgeons and GP anesthetists. And I was called on to help them a fair bit, even in my capacity. And so that just spurred, I think, my true interest, which was surgery.
Do you remember the events of 1967 when Christian Bernard did the first heart transplant in the world? What was your thought when that happened?
I think it was looking back that I finally realized that what had spurred me on in medicine. And I remember sitting in a dental lab practicing some sort of technical skills with the radio on in the background, and there was 125 of us in this lab. And they started talking about this transplant, and it truly, in retrospect, was like an epiphany for me. It was like a light from above. And, the thought of transplantation just captivated me so much that it stayed there, but it really didn't surface for a number of years thereafter. So I did finish my dentistry. I did work for a couple of years, went into med school, and then thought that I was going to make use of my previous training and do head and neck surgery or something like that. When I got to med school, the people that really interested me were the physicians, not the surgeons, but the physicians in heart and lung physiology. So that's what spurred that on, and then I did 3 years of internal medicine before I actually went into surgery, and then I realized I had to get on with things, and my true love was my cardiac surgery, so I started that process.
And then how did you end up in transplantation, cardiac surgery? There's so many different aspects of cardiac surgery. What do you think led you to the actual field of transplantation then?
I think it was that one event, looking back on it, that was always the breathtaking part of it. Oh my God, look what people can do, and look how you can help people. And that really kept me motivated. I did my cardiac surgical training in Ottawa, and they had started a small transplant program, and I was involved as a trainee in that. But the thing that really captivated me there was that I was part of the training and team that did the first artificial heart in Canada with Dr. Keon and his team. And that put me in contact with some of the real pioneers in that field in Salt Lake City back in the early and mid-'80s. So that was tremendously exciting. And from there, the natural extension was transplantation, which really, as I said earlier, caught my attention. And I was recruited to London, Ontario by Neil Mackenzie. And London had the biggest transplant program in our country and one of the biggest in North America at that time, doing perhaps 50 hearts a year. And so that was just enormously exciting, flying around.
I've had the opportunity to speak with Dr. Joel Cooper and Dr. Thomas Starzl and Dr. Richard Lauer in the past, and they had some very interesting obstacles that they ran up against as they began in the field of transplantation. Did you find any of those obstacles as you were starting your career in transplantation?
A little bit. London, Ontario, University of Western Ontario was a very powerful transplant center. First in our country, I believe, to use cyclosporin, one of the first in the world to use cyclosporin in the late 70s. And it was the head of the transplant program. We were, I think, one of the first to actually start a multi-organ transplant unit. And Cal Stiller, a nephrologist and immunologist, I believe was personal friends with Borrell and had access to cyclosporin very early on in this experience. So the resurgence of heart transplantation in the late 70s and early 80s as a result of cyclosporin in Canada started in London, and that was tremendously exciting. So we had a very, very strong infrastructure. One of the areas that I was interested in was pediatric transplantation, and that field, in fact, met some resistance initially, and I think we were amongst the first. Everyone claims to be the first at all sorts of stuff, but I think we were amongst the first to really establish a pediatric heart transplant program in Canada, and reported our results at this society meeting initially in Munich in '88 or '89 at that meeting. So that was a bit of a struggle to get that sort of acceptance. So we were a small center. We had large centers around us. So I would have to say that part of it. And then pediatric heart-lung, which we also started in our country, was very difficult because it's everywhere, such a small volume practice and highly technical, fraught with complications. So for us to do a good job at that was required an awful lot of effort and dedication. So.
But it sounds like your institution actually supported this.
They did.
Yes.
Oh, we were, I was so lucky to be at University Hospital in London. It was a stellar institution in those days.
Great. You were president of ISHLT, 1998 to 1999. I was a director on the board at that time. It's hard to believe that it was more than 10 years already. Describe some of the growth of the society that occurred during this time period.
The society now is so different than it was in many ways, and yet the core of the society is exactly the same. The core values are exactly the same. And the thing that attracted me to this society over the years was that it was truly multidisciplinary. It involved pathologists and clinicians and basic scientists and surgeons and physicians and nurses and coordinators, you know, so really it was reflected life in our field, and that was really rewarding. And I made comment that in the monograph that we've just put together for the society that people don't talk about it a whole lot, but one of the things that was really refreshing about our society was the presence of very strong, talented women in medicine, heart failure particularly. And that was, once again, it kind of reflected real life, and it enhanced our society immeasurably.
What do you think was the most important thing that you were able to accomplish as president?
We had a few things that were mandatory. You know, and it wasn't of our design, it just happened in terms of timing. We needed to select a new publisher for our journal. We needed to select a new editor for our journal. And so that was a very business-like process, which most of us in medicine are not familiar with.
Right.
And so that, I think we did pretty well. Jim Kirkland was a spectacular editor who's just stepped down last year. And he took the journal really to new heights, and a very well-established, very respected journal. And our society, along with that, has grown to a very respected society within the medical community.
What do you see as the future for patients with end-stage heart disease or lung disease?
With respect to heart disease specifically, I've said this many times that as much as I think that the heart transplantation is, and I think I'm quoting Bud Frazier is saying is the biggest picnic that surgeons have ever been allowed to do. It's such a spectacular kind of surgery and patients and results. It really is amazing and such a privilege to be part of that. But the real benefit in terms of statistics over the years, I believe, is the impact that heart transplantation has had on heart failure therapy. There's no question that right now we still do only about 33 or 3,500 heart transplants per year worldwide. But the benefit to heart failure therapy has been manifest in hundreds of thousands of heart failure patients. The care for heart failure now is so much better than it was 25, 30 years ago. It's just a remarkable change. And I think it was the necessity to have these patients in hospital looked after by cardiologists while waiting for transplant. And we found early on that organs were too few, always will be, for the need that presents itself. And the results started to improve in terms of the condition of the patients while waiting, the longevity of patients who were waiting sometimes years for a heart transplant. Members of our society started to say, you know, this therapy is pretty good. Maybe we shouldn't be doing a transplant yet. Mm-hmm. And I think that's been the greatest benefit of transplantation hitherto.
I agree. Have there been any surgical improvements? You mentioned the medical improvements that have helped the heart failure patients. Do you think there have been any surgical improvements?
In the early days, most of the presentations by surgeons were technical, and I participated in that, and our center participated in that, in basically how-to kind of papers for structural congenital heart disease and the different kind of plumbing required to hook up a heart where there has been a congenital malformation in the recipient. And that was kind of fun. The technical part of heart transplantation, really shouldn't say this, but isn't that difficult. It's 4 big anastomoses as opposed to coronaries, which is microsurgery and technically more demanding than heart transplantation. So it became more than that, more than just the technical exercise. It became the evaluation of the patient, the evaluation of the donor and the suitability of the donor. So it encompassed a lot more than just the technical exercise. And then we had the benefit in London of working very closely with our cardiologists, and actually the surgeons took control and managed the patients during the first 2 to 3 months, including immunosuppression. So it was a technical and intellectual exercise, which was wonderful.
And another surgical technique that has come along has been the use of the mechanical circulatory assist devices. And some patients have actually said when they've gotten their transplant that they actually preferred being on the device. What do you think is going to be the long-term future for mechanical circulatory assist devices?
I've always felt that there's a real parallel development in immunosuppression and knowledge of the immune system and mechanical devices. And we've seen that. We've seen cyclosporin was a quantum change in transplantation. The changes up until then were incremental steps. And the same thing in the mechanical. You know, the quantum change was the artificial heart. And the complications that arose from that, bleeding, strokes, immunosensitization, and so on, were things that we had to learn about and deal with over the past 25, 30 years. The devices have changed enormously. They are I think we are really at the threshold now of a real change in mechanical support. The thing that's holding us back previously was the devices themselves and how to look after these patients. I believe the thing that will hold us back in the future is philosophy and how to pay for it. But, you know, in cardiac in particular, it's the biggest problem in our healthcare systems everywhere. Worldwide, heart disease will be the #1 worldwide in the next 10 years. So it becomes an enormous burden for healthcare systems in any system there is. But we've always had to fight. You know, we had to justify heart transplantation. We have had to justify mechanical support to a far greater extent, I believe, than some of the other things that we do, like renal dialysis. You know, the cost of renal dialysis over the entire country here in the United States. If we invested the same amount of money, we could put ventricular assist devices in every single individual who needed it in North America. So we have a pretty big battle in front of us to promote, to advocate, and to justify the use of these devices and newer devices in patients with heart disease.
What do you think of the role for regenerative biology as our future, developing myocytes and repairing the heart? What do you think that role will be eventually?
That's been an enormously exciting development, probably 15 years old now. The first time we saw little bits of heart muscle twitching on a slide in the auditorium that was in a petri dish, you know, everyone went, wow. And so we are learning how complex the simple pump that the heart really is, you know, the architecture, how do you put muscles together, and so on. But, you know, I think we have to go back even earlier in the disease process than that. You know, I think that we have to prevent heart muscle damage from heart attacks, early intervention with primary percutaneous intervention to reduce the size of heart attacks, to prevent heart attacks. So, you know, I think we have to take it all the way back to prevention, which is a very difficult thing to do. Our society and every advanced society around the world has part of its development things that cause heart disease. Too many calories, too many inappropriate calories, industrialized society where we don't have enough physical activity. That's part of our day-to-day life. All those things are causing this epidemic of heart disease around the world.
And so often in healthcare, nursing schools, medical schools, we focus on curing something or fixing something as opposed to preventing it. I mean, how many courses have you taken in preventative medicine? So you're absolutely right. Yeah. You're taking a leading role in robotic surgery in Canada. There have been a few cases reported of robotic surgery in kidney transplantation. Do you see a role for robotic surgery in heart transplantation at any point?
You're getting me to stick my neck out, aren't you?
Uh-huh.
Yeah. In 1997 and slightly earlier in London, we started to think about less invasive heart surgery. You know, cutting through the sternum on every single case didn't seem to be a reasonable thing to do. I think part of it, surgeons really hadn't advanced the field a whole lot from the late 70s, early 80s to almost 2000. A lot more surgeries were done, different techniques were developed, and surgery became an awful lot safer. A lot of that has to do with our colleagues, the anesthetists, who made patients going under anesthesia safer. Preoperative and postoperative care also got better. So we started looking at this other area and developed a number of procedures. In London, we were actually privileged to be what we consider the first in the world to do a closed chest beating heart robotic bypass. And that was exciting. Those were very heady times. Dealing with startup companies and helping to develop tools of the trade and procedures was very exciting. That field has evolved considerably. There's one dominant company now, Intuitive Surgical, that has a very sophisticated robotic device. And what it appears to be, I believe, is that this device actually can do surgery better. Now, it's not, you don't sort of push a button and the surgeon walks away and the robot does everything on its own. It's controlled by a controller, and the surgeon's controlling that. The benefit is that you have tremendous dexterity in small spaces. The robot has 7 degrees of freedom, which is the way your hand moves and so on. It has a wrist, so you can do that, control that. And the camera that you use is a 3D camera that can magnify 10 to 20 times. So you have better motor control, you have better visualization, and you can do a better job in small spaces. So the kind of surgery where it actually has taken over as the preferred way of doing things is in confined spaces, so in the pelvis and things like that. There's new areas in the base of the skull and head and neck surgery. For heart surgery, it allows surgeons to do complicated microsurgery through a small hole. And the net result of that is, I think, mostly a perception by the patient that they're well and haven't been traumatized as much by the procedure. I don't think anyone would advocate that the surgery is better than you can do through an open chest on the heart-lung machine and so on. But there are circumstances where it can be done as well, and even better sometimes as these procedures become more developed. So I think that there's a bright future for robotic surgery in many areas. Heart transplantation, lung transplantation, hard to say at this point. Certainly lung surgery there's a whole field of video-assisted thoracic surgery. And once again, you can still do very delicate surgery in small spaces using this quite safely. In the field of heart transplantation, particularly in mechanical devices, as the devices get smaller and the implantation techniques become less invasive, then I see a role for robotics in that field. And nobody's talked about it a whole lot as yet, but I think that's the way it's evolving if the small pumps prove to be effective.
You seem to be interested in healthcare policy, economics, and administration. How do you see these interests melding with your work in transplantation?
I think it is transplantation, but also a broader perspective. I think the earlier comments I made about how much I enjoy the technical part of transplantation, but the real benefit to the larger group of patients has come from heart failure management and so on. And I look at the rest of the field in heart disease the same way. And as much as I like to operate and sort of lock myself in the OR with my team and do that kind of work, the way you can impact a far greater number of people is less directly. So right now I'm the medical director of a cardiac sciences program in Winnipeg. Within the program we have between 400 and 500 healthcare professionals working to improve heart health in our province, in our jurisdiction. And much of my work is administrative, somewhat political, policy-oriented at times. And the only way I can really get satisfaction out of that is to think that I'm in a positive way impacting the health of thousands of people through these 400 or 500 colleagues that I have. And I think that's the way we can bring the greatest benefit to the greatest number of people.
What do you see as the next challenges for heart and lung transplantation?
I think that the challenges are part of this whole boom-bust echo thing that we've talked about for 25, 30 years now. my generation, the median of my generation will be 65 years of age in 2015. And along with that come all the diseases associated with getting older, heart disease being the first one. So it's going to be a crisis of healthcare systems to deal with all these problems. And that's just the immediate issue. The real shocking thing is that we have a generation now who are entering puberty, who have the greatest incidence of obesity, heart disease, hypertension, and diabetes that we've ever seen. And that's a shocking turn of events that's going to negatively impact health and heart health for the next generations.
And that's true in Canada as well as the
Absolutely.
United States. I didn't realize that.
Absolutely. It's worldwide. As I said, you know, the WHO is really talking about this epidemic of heart disease. You know, this globalization has been a very positive thing in terms of communication, in terms of education, in terms of countries who used to be called the third world now developing into economic powerhouses. India and China are prime examples. Along with that come some of the problems of our kind of industrialization, which I said earlier, we don't do as much physical activity. The food and drink industry produces almost 4,000 calories per person per day in the Western world, and they got to sell those calories, and we buy them and we eat them, and that's causing an enormous problem. So, you know, for all the surgeons out there who think that, oh my God, what am I going to do? There's not going to be enough work. There's going to be abundant work, unfortunately, for generations to come in the field of heart disease.
In the United States, we have found that Medicare and Medicaid, which is our federal insurance, has put some conditions of participation on us. I'm sure you've heard about this, where we now have all these regulatory requirements. I believe it was a 95-page document that CMS put out in 2005, and these went into effect in 2007. Has the Canadian government done any such thing where you have to abide by certain regulatory components for transplantation?
You know, I'd have to say that we are not as well organized in Canada as yet. We have jurisdictional OPOs, which are based in province, within a province or state, and there's kind of a gentleman's agreement across the country on how to do things. We need to formalize that a lot more, like UNOS has. And we are on that road, started about a year or two ago, and with a restructuring and putting the whole transplant endeavor under the umbrella of the Canadian Blood Services. So the whole donation blood thing and solid organ donation is under that one administrative umbrella. So we're now going across, at least not me, but the people involved in that are going across the country getting support for unifying this under a single umbrella. And the difficulty, as you know, is it's great to set policy, but a policy doesn't exist if it's not complied with or enforced. And that's the difficult thing in medicine, as you know.
That's happening in the United States, for sure.
Yeah.
We get our visits from CMS, and they actually come in and look at our quality.
Yeah.
They look at our outcomes and all of that. And I think it has added a tremendous amount of structure to our programs and standardization. So initially, I think many of us were concerned about that, but I think in the long term, it's really turned out to be good for our programs. But it's been a challenge.
Well, I agree. You know, to some extent, one of the problems that UNOS has with Canada is that if an organ is going to come across the border, UNOS has to contact, you know, I don't know, 5 or 10 different organizations as opposed to one number to call, which would make a whole lot of sense.
I have just one last question for you. We were talking about robotic surgery, and I've heard several people say that they practice video games and that helps with the dexterity. Is that just an excuse, or is it reality?
Well, you know, as now a senior surgeon, never played video games, ever. Don't like them. And in fact, even my kids at our house, just never anything we got into. So when I took up robotic surgery in the mid to late 90s, it was a completely different experience for me. I'd have to say that my work in my technical training in dentistry, and technical training in dentistry is much more methodical than the technical training in medicine, where we don't really learn, ergonomics. We don't even talk about ergonomics in medicine, whereas we did in dentistry. So it was a little bit more familiar for me because, a dentist has to look in a mirror and do things with indirect vision as opposed to direct vision. So that concept I could learn, got lucky, could learn that. But we spent literally hundreds of hours in the lab practicing with the robot on, I remember we had an ashtray with a rubber glove stretched over it, and we put little dots on it, and we learned how to sew and manipulate the devices. And literally, I think we spent hundreds of hours in the lab before we took it clinical. So that's how I learned it. And that was with the original computer motion robot, which had fewer degrees of freedom and was more difficult to work. The intuitive robot is much easier, and no pun intended, much more intuitive, because it gives you all the dexterity and more that you have with your own hands. And the visualization, once again, in the early days, you would, like laparoscopic surgery, you have your hands functioning down here, but you're often gazing off onto a TV screen that's not ergonomically correct. I mean, just think of how we write, with our hands below our eyes and our gaze like that, and then to try to do something here and be looking at a screen over there makes no sense at all. So that's part of the ergonomic thing that has happened over time with the robotic devices.
Well, I want to thank you very much for sharing your thoughts on many different aspects of transplantation and economics. So I really appreciate this. Thank you. This is very helpful in the society capturing some of this history. Thank you.
Well, thank you, Linda. It's been my pleasure.